It is my great honor and pleasure to introduce our distinguished plenary speaker, Dr. Paul Harris. Dr. Harris is a professor of biomedical informatics at Vanderbilt University, the director of the Vanderbilt University Medical Center Office of Research Informatics, and the associate director of the Vanderbilt Institute for Clinical and Translational Research. He's also the principal investigator of the transformative All of Us research program, a flagship of NIH's Precision Medicine Initiative. The All of Us research program, as you will hear, represents a bold effort to revolutionize healthcare by building a diverse, longitudinal data set of 1 million individuals. Unlike a one-size-fits-all approach, this integrative approach recognizes our unique differences and aims to provide personalized health recommendations. Dr. Harris invites each of us to engage with the All of Us program, to contribute as researchers, and to help unlock the potential of this incredible resource. Beyond his leadership with All of Us, Dr. Harris has profoundly impacted the global research community. He is a visionary behind the creation of REDCap data platform, which now has 2.5 million users in 151 countries, facilitating research on a global scale. Please join me in warmly welcoming Dr. Paul Harris to the stage.
So thank you for that kind introduction, and thank you for the invitation to be here. I've been looking forward to it for some time. So I'm going to start. I'm going to talk about all of us, but first I'm going to talk just a little bit about REDCap, because I just came from a REDCap conference down in Florida, and there were about 500 folks down there, and I made the decision before going that I would try to meet every single person and get a picture, get a selfie made with them. So my wife, I told my wife about it. It's about a week and a half ago, and she said, "You'll never make it, and plus you'll get COVID." So I did not make it. I got about 125 folks so far. So good on the COVID prediction, but I did meet these 3 folks. Evie, Jordan, and Ehab from Stanford, and Stanford, and also we have a very long time collaborator, Andy Martin, here at Stanford, that has been just a fantastic colleague and collaborator over the years. So I wanted to start with just that shout out to those colleagues. But for the rest of the slide deck, I'm going to be talking about All of Us. So All of Us is a fantastic program in my mind. I've been in informatics for about 25 years at Vanderbilt, studied as a biomedical and mechanical engineer, worked in the space industry for some time, went back to school into biomedical engineering, and then just kind of gravitated towards biomedical informatics. And one of the things I remember thinking about while I was in the space industry was I'm old, but the people when I was young, they were even older. And they were walking around, NASA, and they were the folks that built the original lunar missions. And I thought, man, wouldn't that have been a cool time to be alive and to be able to contribute to something like that? I bring that up because I think all of us, for me at least, from a career perspective, is a moonshot type of program, and I love it for all kinds of reasons that we'll talk about next. So the platform itself, is designed, with 3 program missions. One is to nurture partnerships for decades with at least 1 million participants. I think we'll go much more than that over the years, but at least 1 million participants who reflect the diversity of the United States. Those individuals, that partnership with those individuals is a partnership, but part of that partnership is donating data from electronic health record systems, donating DNA, donating survey records. We'll get into that throughout the talk, but throughout that, having that information means nothing unless we can make it useful. So another part of that middle circle is curating data sets, making them available for researchers in a way that fosters scientific progress. And then finally, to catalyze an ecosystem of communities, researchers, and funders who make all of us an indispensable part of the research infrastructure, specifically by the NIH. So this doesn't happen by accident. No good things happen by accident, or at this scale happen by accident. So made possible by a team that really has built a culture around the program values. The program core values are as stated on the screen here. Participation is open to everyone. Participants should reflect the diversity of the US. We spend a lot of time in all of us in recruiting and retaining individuals that are underrepresented in biomedical research. Participants are partners, not just donators. Trust will be earned through transparency. Participants have access to their information. The data will be accessed broadly by researchers everywhere for research purposes and scientific hypothesis generation and discovery. Security and privacy will be of highest importance, of course, and the program will be a catalyst for positive change in research for years to come. So currently, this is the status of the All of Us data set about August 12th, earlier last month, about a month ago. We have 828,000 participants. Those might be anywhere from full core participants to they're donating everything to maybe they just sort of expressed an interest in creating an account. 565,000 of those have created the initial steps of the program, which I'll talk through in just a few moments. We have in that set 452,000 individuals that have donated electronic health record that we're curating to make available to the researchers, and over 500,000 biosamples, urine and blood samples that are useful and usable for research. The right-hand side of this screen is a map of participants. You can sort of see where people are in the United States that are in the data set or in the program. And then the bottom right gets at that underrepresented in biomedical research. And so, we don't just think about race and ethnicity. We also think about rurality, disability status, income status, and you can see some of the other categories there. But it is quite a diverse data set and population. Speaking of rural, we did a count a few weeks ago again, and about 73,000 participants from rural areas, and you can sort of see that progression over time. 1 in 4 rural participants are living with a disability. 1/4 of those have limited access to healthcare, and so I don't need to tell you that these are complex issues to deal with for anyone, but especially our rural populations. As I mentioned earlier, this is a big program through the NIH, and you can see most of the partners there with logos. Mine's Vanderbilt University. It's way down in the bottom on the right side. In the Data and Research Center, we're partnered with the institutions that you see there, and the DRC is responsible for getting the data in, curating it, and making it available for researchers in a way that they can use it in practice. All of us participant experience usually starts with a login. So the website that you see here, has a Join Now button in several different places. You're asked then to create an account. So an email address and a password will get you started. At that point, we were asked to review consent language to be in the program. We don't have a one-size-fits-all consent process, so because we know that some people are comfortable sharing their EHR data and some people are not comfortable with that. So we want to make sure that, and same with the genomic data, et cetera. So we want to make sure that, again, that inclusivity and there's something here for everyone. That we're designing into the process, but there are consent documents to review. If you wish, you agree to share your electronic health record data. You complete the consent to get DNA results, and you also answer health surveys. There's a number of different surveys, and I'll kind of go through those in a future slide, I think. But those range anywhere from demographics type information to healthcare access to social determinants of health. And then finally, once you've reached a certain point in the process, the consents are done that you are going to for those individuals that are going to donate electronic health record and are okay with genomic samples. They visit a partner center, or there are coordinators out in communities that can come and visit you in your home to get physical measurements and biosamples. These are the types of data that we're currently collecting. Electronic health records I've mentioned several times, and you can see sort of the subcategories of that over in the first row. Participant surveys, and you can see the different types of participant surveys that are currently available. We don't ask the participants to complete all of the surveys before we make that visit to get physical measures and biosamples, but we do ask them to complete 3 of them. And we found that having just that little bit of a speed bump or a little bit of an investment from the side of the participants makes a big difference when we're talking about next steps in the program. Physical measurements, you can see biosamples. We're collecting blood or saliva and urine. And we also are collecting wearable data for anyone that wants to participate. There are programs. There's a WEAR program that once you're in the program, and particularly if you're in certain underrepresented in biomedical research categories, we'll send you a Fitbit, and people tend to wear those and donate those data to the program. So I'll talk a little bit about that later as well in terms of some of the science that's being done. So I want to talk first a little bit about return of value to participants. The obvious here is the genetic research reporting, and so we have actually 4 different types of reporting that we do. 220,000 of all of us participants have now viewed genetic ancestry reports. And you can sort of see the sub-regions, 7 regions, and there are 20 sub-regions where those genetic ancestry reports are designed specifically for participants. We have recreational genetics, and so if you're interested in what your genes tell you about liking cilantro or not, or sticky or dry earwax, that sort of thing. Those are available, and many of our research participants have enjoyed those. But then we get down into the medical domain. So this again requires an individual to say that they want their genomic results, their health-related genomic results. But if they do, then we have a process so that those data, those findings for the ACHG59, the genes associated with serious health conditions, including some of the ones you see there, can be presented back to the participant. We do that with genetic counselors, of course. And if there is an issue that an actionable finding and it needs to be converted into a clinical report, the program will actually help with that as well. And then finally, we've got medicine, the pharmacogenomic data that can go back to individuals. Interestingly, on that one, we've had 143,000 of our participants have viewed that report. And the vast majority of participants who receive this report have some result that could potentially impact how their body processes medication, and with that report they can give it to the doctors and have useful information. The current screens, we're flipping this up a little bit. It's going to look a little bit different. It's starting in December, but the current screens look like you see here with the DNA results, and you see that this is an individual this is a screen of an individual that's looking at the opportunity for getting those results back. Again, we want to reserve the right for an individual to say yes or no. I'm interested in that results coming back to them. But if they do, this is the starting ground, and this is these are two of the reports: the medicine in your DNA and your health-related results, as you see here. Other ways that we're providing information back to participants or returning value back to participants is, we found in speaking with our participants, they're not only interested in just donating their data, they're interested in, well, what's happening. I donated it to further science, and so what's happening with that. And so one of the things that we have on the Research Hub, which I'll talk a little bit about in just a moment, is a listing of all of the active projects. So an investigator gets into the system, they start a project, they're required to enter information about what they're doing and what the outcomes are expected to be, et cetera. And so within a very short amount of time, those are posted on the public website so that all of the community can see what's going on there. Publications take a little bit more lag time. But those are starting to come in, and I've got a slide that sort of shows the progression of those in a little bit. But we also, this is the place where we put publications that have used the platform and the data for completed work. So let's talk a little bit about the researcher data. One of the most complex things is that electronic health record data. And also one of the most complex parts of the program is how do you recruit and retain those individuals from all over the country. Just looking at the EHR side of that, the HPO here stands for Healthcare Provider Organizations, and the DRC stands for the Data and Research Center. That's that program that I lead at Vanderbilt. So we work with the different healthcare provider organizations, and when someone signs up to be part of the program, there are processes and policies for readying electronic health record data for contribution to the All of Us platform. That gets transformed to source data. So the source data from the EHR records gets transformed to a common data model called OMOP. We then use that OMOP data. We do lots of curation steps and privacy checks, et cetera, around that. And then we make it available to the research teams. Here's some screens. This is kind of a neat screen because the program didn't start collecting data on individuals, I think, until 2017. But as you can see with electronic health records, if I'm donating my electronic health record and I've been in a hospital system for a long time, we actually have data going back to the 1980s on some of these individuals. So until very recently, we weren't working in the pediatric space, but we still had plenty of pediatric type data from at least from the electronic health record system information that's coming in. So data that's currently in the system, we're just about to do another data version, which I'll tell you about in a few slides. But currently, we're on CDR, or Curated Data Repository version 7. That's the one that's available to researchers. We typically do a refresh of that every year, adding new data types and also a truing up of the information that we've received on the same participants, as well as adding new participants. It's also the right time if people want to discontinue participation in the process. It's also the right time to remove their data from the next version set. But at least the one that's active today, at least for another month or so, I think, we have participant surveys, almost 2 million of those completed, 287,000 EHR records. You see you see the other numbers here. I'll point out wearable tech, about 15,600 in this new release because of that WEAR protocol I talked to you about. I think that number is going up. Man, I can't remember. It's somewhere to close to 60,000, I think. So it's just sort of the power of having people consented, having them participate, and having data streams that can be updated over time with that consented cohort. And then you see some of the measures around omics, particularly genotypes. We've got whole genome sequences on 245,000 individuals that are available to researchers right now. We're going to have much more in this next release. So I'll point this out a little bit later when we're talking about sort of scientific impact of the program. But one of the things that's been striking to me is, you start combining the survey instruments in the exams with the genomic data, with the health record data, and add in the Fitbit data, and even that Fitbit data of 15,000. When you start bringing all of that information together and aggregating it, you can just do things that you couldn't do before and answer questions that you couldn't answer before. And so we're looking forward to other data sets. We were working with an ancillary study with the Nutrition for Precision Health group that's going to bring in proteomics. I think we're working on other projects that might allow us to get environmental data, imaging data, et cetera. So we're not there yet, but we're sort of on this evolving process of getting and linking more and more data. This one's kind of to that point. If you look at the overlap of the data sets, we have 206,000 again in this current release, not the one that will be released soon, but in this current release, we have 206,000 individuals that have genome data, that have electronic health record data, that have the physical measurements and surveys, and you can sort of see on the right side there, how that sort of overlap goes with different data sources. So, as I mentioned, the CDR version 8 release is coming soon. This will have, I think, I know because it's in my slide. We have a data cutoff of October 1st, 2023 for this data set, and we're really close to releasing it to the larger community. We've got a little bit of wiggle room towards the end of the year, so I can't give you an exact date, but we're looking hard at making that available soon. And as I said, we try to release at least one time a year. Race ethnicity subcategories will be in this data set. So new data sets will be that WEAR protocol with all of those Fitbits, especially those associated with folks in underrepresented for biomedical research categories, life functioning survey, survey instruments from Care Evolution platform. That's one of the platforms that's going away soon in December that I mentioned. We've got sort of a new point of entry coming. Deceased participant reporting. So this would be if healthcare providers say, this individual was in our protocol, was in the program, but now they've deceased. Remote height and weight individuals collecting their own data, and some participant mediated EHR data. So those are new data types that are coming in soon. But again, the more impressive is the addition, a whole year's worth of new data coming in for new participants as well as older participants. So I want to shift now, and let's talk a little bit about the researcher access. So we've talked about the participant journey, a little bit about how those interactions go in the recruitment process and the data collection process. And now let's sort of flip it to, we're now wanting to make the data available to all of us. So the first slide I always give here is just a reminder to talk a little bit about privacy. And also the goal of broad and open access. This is like a tug of war. We want to make the data as freely available as we can to as many people as we can with as low a burden as we can. But at the same time, we do have a commitment to our participants to maintain their data privacy and do de-identification, not in the easy in the easy ways of just sort of pull a few types of fields out and do some date shifting, but do that in a comprehensive way, so that we're all sleeping well at night, knowing that the trust that the participants have in us is earned and maintained. But again, at the same time, nobody's giving their data so that we can lock it in the basement of Vanderbilt Medical Center. We need to make it available to researchers for the program to really work. So I mentioned that just to say, as we go through, as I talk through, a little bit about how we do this, you'll kind of understand maybe some of the guardrails that we put up on both sides. So we have 3 tiers currently of data access. One is a completely public tier. You could just go there. I'll give you the link in just a moment, or the QR code in just a moment. You can go there and just start playing around with the data, as I'll kind of show you in just a moment. We don't allow row level data playing around in the public data set for reasons of privacy that I mentioned. And we even limit some of the things like you might expect to be there, like cross tab queries, because really clever people could do that 1,000 times and start and with information that an individual is in the all of us data set, and they could start with the identification process. And so really we built a public tier to allow people to sort of come in, understand what's there. And if you're a funder, or if you're just an interested individual, or a participant, here's where you would come to sort of find just sort of high level information about what's there, how it was collected, all the SOPs, et cetera. And for the researchers, we really want it to be enticing. So this is fantastic. And if you're studying if you're studying mental health and thinking about pairing that with Fitbit devices and maybe medications from the EHR, there's something here. There's probably something here for you. So you should take that next step of joining the research workbench. Here we have 2 tiers as well. It's kind of a passport model, and I'll explain it in a few slides. But it's sort of a passport model. It doesn't cost you anything, but your institution has to sign a data use agreement with Vanderbilt as the system owner for the platform data. And once that happens, any researcher, so I'll just say at Stanford, once Stanford is signed on, which I'm sure they have, then the next researcher that needs access just goes through a few processes, and within an hour or so they're in and they can do the work. But once you get in to do the work, with that passport, it allows you to 2 tiers of data, depending on your institutional preference and what they're comfortable with. One is called registered tier, and one is called controlled tier. The registered tier researchers can see surveys, they can see electronic health record data, they can see physical measurements and wearables. Dates are shifted. We're obfuscating some of the categories on race and ethnicity and sexual orientation, et cetera, because again, it's from a privacy standpoint, we want to be very careful with that registered tier. We want to be very careful with both. But the controlled tier, allows us to include the genomic data. It also includes us to not do the date shifting that I mentioned earlier, and allow less of the data obfuscation to happen on some of the data fields that we have. They're both very secure. They're both very safe. But that controlled tier is a little bit more researcher friendly if you need those data sets and that specific granularity. The research hub looks like this. I think it's researchallofus.org. You can see the QR code there if you're interested. And I'll just kind of take you through a few screens now on the public functions and features. So this is called the data browser. And this is my favorite. So if I'm talking to anyone and they say, hey, what's going on in all of us with respect to mental health research, or a specific type of mental health issue, the first thing I'm typically going to do is open up my browser, get here as quick as I can, and type that into the data browser. And that data browser will look across the different domains of data that we have. And anytime there's a hit or a connection, it will show a card like you're seeing at on the bottom of the right hand screen there. If I then click one of those cards, it will show me something like this. This is the top 10 conditions by descending participant counts. I'm showing another one here where I typed in the high cholesterol. You see here I've got 20 types of data element that might be interesting in this space of high cholesterol. 5 conditions in the electronic health records, 1 survey question, probably do you have a history, do you or your family have a history of high cholesterol, et cetera. But once I click on, again, any of those cards, it will take me to the type of graph that I showed you earlier, or in some cases, in most cases, you can drive down just a little bit deeper and show it by gender or show it by age group. This is where we sort of draw the line, because any additional crosstab querying kind of could potentially get into the privacy domain, but it's usually enough. The other place that I'm going to get to this in another slide, so I'll wait. But to get that access to the row level data for analysis, again, first you confirm your institution is part of it. If you're not, then there's a quick recommendation of here's what you should send to your Office of Research, or here's how to connect in with the Data and Research Center to start the process. It doesn't take long. It's language that's been vetted by a whole lot of institutions now. But once your institution has signed, then at 2 a.m. in the morning, any researcher at Stanford could go to that site that I mentioned. They could start the sign up process. It's creating an account. There's a fairly stringent identity verification that happens. There's some mandatory training from an ethics perspective, and then they're signing a data user code of conduct. I should have mentioned, I'm going to go back one slide. Sorry, I'm going to go back several slides, and then I'll come right back. But I should have mentioned that when we were talking about the registered and the controlled tier, the data have already been deemed not readily identifiable by the IRB. And so you don't need an IRB protocol. You start with that 2 a.m. process that we were just talking through. You have your idea. The next level stuff after you get in would be to create one of those workspaces that has the descriptions on the public page that I just mentioned. But by 3 or 4 o'clock in the morning, I wouldn't recommend that actually, but if you're a night owl like I am, by 3 or 4 in the morning, you can actually be working. Once you get in, with that process that I just mentioned, then basically the registered and the controlled tier processes look kind of the same. It's just different data sets that are available. So everything kind of starts with a workspace. That's how you could describe a project. You might create a workspace, but also you might bring in 3 of your colleagues that are already vetted in AOU as collaborators into that workspace. There's a really nice graphical user interface cohort builder. So being able to sort of point and click and say, I'm looking for individuals with these phenotypes, maybe with making sure that they have genetic data. Or even specifics on the variant data, as well as want them within this age group. So a really nice WYSIWYG type graphical user interface that sort of gets you down to defining cases, and you can also use it to define controls. Once you've sort of built that cohort, then you sort of use a data set builder to say, hey, I want to work with this data. I want to bring that into a notebook, and I want to bring in these specific data sets. You can always come back and get more, but that's sort of the linear way of moving forward. Once you click on the notebooks, create a notebook here, then you're basically given access to an environment, a Jupyter Labs environment that's familiar to most data scientists, and will allow Python programmers and R programmers to go get access and do the specific data analysis. We also have just released another point and click tool, SAS. So if you're a SAS user and you want to sort of access it that way, then that's available now as well. And then throughout the whole process, there's a lot of user support hub work. So these are public materials. There's opportunities for Friday office calls, et cetera. We do a lot of support, making sure that the researchers not only can get in, but they can do meaningful work once they're there. I think I mentioned that this is actually just a screenshot of the dashboards. Here I've got 4 workspaces that you can see on the top. I should also mention there are also example notebooks. So if you're thinking about doing a GWAS analysis and you're not exactly sure how to do that, there's all kinds of template notebooks that you can copy and start from there rather than starting from scratch. And I mentioned Python, RStudio, and most recently SAS. So this is just a really quick set of slides around just the process for doing one of those GWAS studies. This was, I think this was done by somebody in my group. It may have also been replicated by someone else, but before we released the controlled tier, we wanted to create one of these notebooks, example notebooks that I just mentioned, so that people wouldn't be having to figure this out on their own. So this was part of one of those projects, but an individual used the cohort builder to find individuals of interest with and without type 2 diabetes. Use the data set builder to say, hey, I want these data types, including the genomic data, EHR phenotype data, and the EHR data, and the genome data. And then they click that, let's start a notebook. That notebook, allowed them to run a series of coding commands. It took about 30 minutes. This was an example set of about 5,000 participants. About 10 million variants across those 5 million participants, but all in all, the GWAS analysis took about 30 minutes, and it cost less than $30 of compute time, which I'll talk about next. So researcher cloud costs currently, the way this works is, your cloud costs. Currently, the next slide talks about some free credits, so I'll get there in just a moment. But for everyone, the amount of compute and storage costs sort of depends on what type of research that you're doing. Turns out the electronic health record data is pretty minimal when you compare it to some of the omics data sets, right? And so you can do lots and lots of EHR type data analysis and survey analysis, et cetera, for pennies, pennies or most dollars. But if you're getting into some of the higher power compute environment stuff, then the horsepower as well as the data storage around those can add up to more money. Regardless, there are processes within the workbench where you can sort of define, this is the type of compute, environment that I want to sort of pull up into this cloud and based environment, and you can sort of control your own destiny there with data, compute resources, time, and storage. We give away currently $300 in initial credits to anyone joining. Once the credit runs out, and I should say that the vast majority of studies that I've seen or workspaces that I've seen, they at the researcher level, they spend far less than $300. But if you are spending more than $300, then there's a process for signing up and inserting your Google billing account information that can allow you to do just whatever you want. I've found not just in the All of Us program, but in my other work at Vanderbilt and sort of the big data space and thinking about cloud infrastructure, et cetera, that research billing is one of the hardest pieces. It's not exciting. It's not fun, but it is one of those most difficult things to kind of work through at the financing and admin level. But fortunately, you can move forward with a whole bunch of stuff before and perhaps never need more than that. So researcher information, I pulled these slides a couple of nights ago, and I think we're at very close to 12,500 total researchers all time. You can see that about 7,500 of those are active right now, and active, I think we're defining as, we've seen them in the last year. So there's a re-up process every year that people have to go through, and so we sort of if they don't go through that, then we don't call them active researchers. But you see on the left and the right side, I'm not sure if you can see the fine print there, but the take-home message on the left side, we ask people for institutional roles, and what we see is that there's a lot of people in lots of different roles that use it, across those 12,500 individuals, but it skews a little bit more towards junior faculty and trainees and so forth, which is fantastic. I should also say that that doesn't mean that the most senior PI at Vanderbilt isn't using it. It's just usually the ones doing the work might be the ones that are more junior faculty. So you sort of have to sort of take all of that with a grain of salt and sort of build your own story. The right side is the educational attainment. Mostly people with terminal degrees, as you would expect. But we've actually got some high schoolers in there that have done some interesting and meaningful work. So it's a cool environment for all. This is the workbench usage over time, as well as some key milestones in the program. So I won't belabor the point with reading a lot of this, but you see the first one in 2020. That was when we first launched the registered tier. Before that, it was public tier. The reason we needed to wait was it takes a while. This is a cohort, a building cohort. It takes a while to have enough individuals to be really meaningful and interesting to researchers. You can see a little bit later, we went with the refresh. You see sort of a hockey stick type curve inflection when we start talking about the controlled tiering, getting the whole genome sequence and array data in, and you can see some of the other milestones, but the bottom line is, people, we've all done a lot of work from the participants to the recruiters, to the data people, to the platform builders, and it's starting to pay off very well. These are, we ask people to call their shot a little bit. What types of research are you doing in, with these workspaces? And you can see some of the categories there. No huge surprises there, but I think that's probably a good thing. But you see, there's quite a bit of diversity. Most looking at specific diseases. I love the education bucket, because I think this is, just a phenomenal education tool. I've taught in my graduate level informatics, clinical research informatics class. Here's the principles of what we're talking about with data privacy, or here's the principles of what we're talking about with OMOP standards. Now next class, let's just jump right on into all of us, and we'll just kind of show that in action. And so I've done that personally, and I know a lot of people are building it into courses as well. So just a few minutes left. I want to talk a little bit about scientific impact. Before we get into publications and sort of completed research projects, I'm very proud of the fact that because of the intentionality of the recruitment process, and including, not just including, but prioritizing those individuals that are traditionally underrepresented in biomedical research, both on the participant side as well as the researcher side. I think we have one of the most diverse data sets, genomic data sets in the world. 77% of the individuals there are underrepresented in biomedical research, again, using all of those categories that I mentioned earlier. The right-hand graph there is information from the GWAS Diversity Monitor.com, which is a really cool program. I think they've assessed maybe 6,000 studies or papers at this point, and they kind of keep track of those repositories and what's the racial diversity among those, and you can sort of see some of those there. But I would say that all of us, because it's US, because it's so intentionally focused on diversity, I think we've got a much deeper data set than many of the other biobanks. This sort of makes that point as well. We've if you look at 1,000 genomes, or NOMAD or TopMed, you sort of see the number of millions of variants there. Again, because of the diversity of the AOU population, we have a tremendous amount of variants that we've seen. Last time I checked, we were in the top 20 of contributors to ClinVar based on volume of submissions. And again, it's a relatively new program. Leaving genetic data for just a moment and just thinking about the EHR data. Again, if you're interested in a specific disease or condition, the best place to find that usually is going to that public browser and just sort of kicking the tires a bit. But we put this chart together that kind of shows, some of those here, and you can see, see the different categories there. There's a few, particularly on the right side there, that I think would be very relevant for mental health. Publications, this always takes a while. Whenever you start a new program and you're delivering data to individuals in that program, it always takes a while to get the publications going. But I love this chart because it looks like we really sort of hit the inflection point from linear to nonlinear, as you can see on the right-hand side, with 600 total publications, citing and I think 450 or so that are specifically using the platform and the data set. I want to give you just 3 examples of my favorites, and I'll tell you why. This one was done early on by a graduate student named Patrick Wu. Patrick was at Vanderbilt. He used our homegrown biorepository and DNA data set, as well as our de-identified data in a program called BioView, to look at drug repurposing. And specifically, he was looking at which drugs, just looking at the EHR and mining data, which drugs might be that are not commonly thought of as impacting. What was he studying? Hyperlipidemia, as well as I think high blood pressure. And he then, so he did an analysis. He went from thousands of potential drug candidates to just about 15 or 20 of those, and sort of this was part of his dissertation defense. Somebody as dissertation defense looked at it and said, "This is really interesting. You boiled it down to maybe 15 candidates across those two diseases that might be interesting to study next, but you're just working at Vanderbilt. So how do you know these data are going to sort of scale beyond Vanderbilt?" So it took him about 2 years, I think, to do this work. 3 years. 3 years. That one question, what about replication? It took him a week to come back and use all of this data set. Some of those didn't replicate, but some of them did. And so, I love that story because I think it really sort of speaks the power of this for even replication and not just novel new science. I also liked it because Patrick lived down the hall from me, and I enjoyed seeing him in the hallways, and especially knowing that this was a resource that helped him. This next one is a favorite of mine for 2 reasons. I love the science and I love the direction of the science, but I also have a personal connection to this, and I'll tell you about that in a moment. There's a guy named Evan Britton that has done some phenomenal work looking at that Fitbit data, that activity data. I have to tell you that when I looked at the numbers for the activity data early on, I think he started this back in data version 6, even less data than we have now in V7. But when he started looking at this, when I started looking at it, I thought, it's just several thousand of those. I'm not sure you're really going to be able to do anything interesting until it gets bigger. But he started doing stuff that was pretty interesting pretty quick. And again, it's that marrying data. First he looked at marrying the EHR data with the electronic health record data with the step counts and so forth, and he published the paper on the left there, Nature and Medicine, around association of step counts over time with the risk of chronic disease, and he picked out several chronic diseases. Then he's kind of moved into, hey, now that we've got the genomic data there, what if we pulled that in? And he's done polygenic risk scores for obesity, and he's looking at sort of dose response type curves to watching how active people are versus their obesity status. And he's really seeing that this polygenic risk score, you do see separation in those groups, as you can see in the bottom figure. And then finally, most recently, we started in the last version of the data, we started also sharing the sleep activity. And so he's starting to look at sleep patterns again, sort of combining those data sets together and linking those data sets together to tell interesting stories. My personal story on this is my mom's in the program, and she doesn't get excited about anything except for the fact that the program sent me one of these Fitbits, and she talks about it all the time. And she's walking more. And I mean, it's really, really cool to sort of see it. The other one is my dad. My dad called me shortly after the first publication here came out. And he said, hey, I saw this thing on CNN and it's, it's talking about Fitbits and big, it's collecting lots of data. You should check into that. I said, I'll do that, Dad. but it was one of those rare moments when I was able to tell my parents, hey, this is what I do. And this is kind of how it makes sense. So I love those stories personally. Okay, just a few more. This is a study by Dr. Zhang et al. Looking at just the phenotypes that are present in the biobank, in the UK Biobank, and in all of us. In the interest of time, I won't go into details, but the bottom line of that was that we see a lot more representation of phenotypes in all of us than perhaps we see in the general population of the U.S. And certainly when we compare it to the UK Biobank. We love the UK Biobank, so I don't mean to sort of draw a bad comparison there. But again, I think it shows the intentionality of how we're collecting the data from diverse participants. And then finally, this is not pretty at all, so I apologize for that. But since I was coming, we've recently created this generative AI bot that allows us to ask questions about those papers that are coming out of the program. It's still not ready for prime time, so it's not on the public browser yet. But I just asked it a couple of days ago. Hey, tell me about publications that have already been published that are supported by the All of Us program that have a mental health component, and you can see some of the ones here. I think there are more. In fact, I know there are more. But I think it's a good thing that we're starting to see a lot of work in this space. Okay, I'm going to skip. I'm out of time almost, so I'm going to just skip the next few slides. Other than just two more. I've got 15 seconds. I mentioned pediatrics earlier. We developed a lot of protocol work. Sarah Van Driest at the NIH developed a tremendous program in pediatrics last year. We've got all the engineering stuff built to make it work and sort of run the program. We're in sort of a little bit of a delay for launching big right now because of some funding issues that we need to work through. But we're very, very close to infrastructure-wise. We're really close to being able to sort of turn the curve on enrolling pediatric participants. We do have some enrollment going on right now in the 0 to 4, so it's an accurate statement to say we're doing pediatrics. But the better thing is we're really poised to do bigger pediatrics soon. And I think with that, I'm gonna end with this scientific priorities roadmap, which kind of talks through the Jeff Ginsburg's, who's the chief science director for the program, who is thinking about where we go next with the program and specifically the science committee. Any questions?
Thank you for such an inspiring opening plenary. We're open for questions and we have 10 minutes.
I think I saw this first.
Thank you so much. It was very remarkable, very interesting presentation. In the subset of the cohort, some of them they had custom arrays and they had whole genome. What is the decision that some people can do this customized versus something that?
So if you submit a biosample, as part of the consent process, then we now have an opportunity to do the sequencing. We do both array work, but also whole genome sequencing on everyone, and we make that available to the researchers. Perhaps the distinction that I didn't speak well about was the choice that the participant has on receiving data, receiving information back on that. So I as an individual may be fine sharing my DNA for science, but don't tell me about it. Or perhaps it's do tell me about it. So I think that's probably the distinction you were picking up. Does that sound right? Okay. I think I had back here and then here.
Thank you for the wonderful presentation. I'm thinking about the type of data that you're collecting the index generating students, qualitative data that sort of what's the most important sense of data? This is done such a wonderful job in collecting data from funding to the population that is making the what are the top health concerns, the health
Yeah, thank you. Thank you. Yeah, I think there are opportunities for that. So I mentioned briefly ancillary studies, and I mentioned it in the context of we're working with the Nutrition for Precision Health team at the NIH, using the platform to support precision nutrition studies. But that's just one ancillary study. There are a lot of ancillary studies, and I personally think this is going to be the most exciting part of the program going forward, being able to do sub-studies like you're talking about, whether it be in that qualitative domain or whether it be, I mentioned the environmental data, bringing that in. And so bringing in participants, bringing in new data sources, and bringing in new opportunities for those participants. That's very much part of the ancillary study playbook. Thanks. Here and then here. I think you were next.
Thank you for an excellent presentation. Two questions. One, we're all interested in real world data. Can you discuss the selection bias for people enrolling in All of Us? Seems that they have to have computer access, wearable access. That's my first question. The second, there are other national databases that may overlap, NHANES in general and SEER for cancer. Have you looked to see how comparable your data is to those databases, in particular if there are overlaps in enrollment?
We have done so. That was kind of a multi-part question. So let me start with the digital equity, if you will. So yes, I mean, you do need a computer or a smartphone to register, unless you go into one of the HPO sites directly, and then you can, they can kind of walk you through it. For the surveys, we have computer adaptive testing, that can be done over the phone or read over the phone, that allows streamlining of individuals into the program that are underrepresented in terms.
My concern is particularly rural areas.
Right. Yeah, agree. The other thing you said was Fitbit, and that one was, that one, I have an opportunity to link my Fitbit account to my All of Us account, but I haven't been selected as one of those Wear protocol participants, because we're trying to be intentional and serving the underserved there. And then finally, your question about the overlap and the comparison between things like NHANES and other programs. It's a tricky one, because this is a consented cohort. We are doing, I think, a lot more real world data, as you mentioned, than the very strong epidemiology focused programs. And so we've had to sort of take that into account in terms of how we counsel our researchers to think about, or you could even think about policymakers thinking about this data, that we have to be very cognizant of what it is and what it isn't. Yes.
Thanks for a great talk. Could you say more about the potential for precision nutrition using this data set, and what kinds of dietary data you're collecting, and what kinds of studies you have in mind to learn more about precision nutrition?
Sure. So there's a big program going on right now. It's called the Nutrition for Precision Health program, and you can look that up. It's easily findable on Google. It's an NIH product. But it's basically a group of individuals that are in all of us or will join all of us to become part of the platform so that we can get all of the non-nutrition data for them. But we can pair them with prospective nutrition trial type data that are being collected now in three different modules. One sort of free living, going to the other end of the spectrum, some in a metabolic chamber, and being able to sort of collect some data types specific for nutrition research, like microbiome type data. So different data types than I've talked about so far. They're using the platform. The big take home of that one is going to be hopefully some machine learning algorithms that really sort of help move the needle in terms of predicting, precision nutrition, for both habits as well as metabolism in individuals. Those analyses are still in the field doing the data collection right now, but the analyses should start, I think, next year. And then hopefully soon after, we'll start making the larger data set available to the public AOU research teams. Thanks. Yes.
You may not have looked into it, but is it that you have a large number of participants, but are they enough to have some leads about the genetic predisposition to certain mental illnesses?
The last part, I'm not sure. So let me remind you that I'm a biomedical engineer. I build stuff, and I'm not a mental health expert researcher. But I have seen a lot of projects. I have seen a lot of papers coming in saying that with the combination of these data that there's enough. And again, as I mentioned earlier, I think we're raising. We're either increasing our data set by 50%, or I think it's like 57%. We're increasing in this next version that comes out in terms of the number of participants with EHR data. And I want to say we're going from a couple 100,000 to 400 and something thousand whole genome sequences. And so my answer would be, I think so, but if not, wait for the next release. And I'm pretty sure I know so. Yes.
I was very interested in what you said about gathering nutrition data.
Mhm.
Nutrition directive, and I just want to caution you about using nutrition data off the internet, because 44% of the nutrition data on the internet is wrong. Okay, for instance, the Global Food Branded Database of the USDA, 44% of it is actually wrong because they take the information from the manufacturers and put it on. They don't test it themselves. We've actually, demonstrated that to Naomi Fukugawa at Hyattsville.
Right.
And she said, yeah, I know, but there's nothing I can do about it unless Tom Vilsack gives me a whole lot more money.
Okay.
So be forewarned.
Great. Thank you. And I should give credit where credit is due. We have a lot of nutrition researchers that are working to design these studies, and so I think they, I sit on the steering committee, and I know the rigor that's being put into this. So I think it'll be fine. But thank you. Thank you. Oh, sorry. One more.
I know we had one more question, so please catch Dr. Harris in the break. Thank you again for a fantastic opening plenary. And we will now move to a break. So we'll have until 10:30 chat, meet with the speakers, and we'll see you back here for our wonderful keynote program at 10:30.